Hi, everybody. I'm Adam Hoffberg, and this is the Rocky Mountain MIREC Short Takes on Suicide Prevention podcast. Joining us today for our guest host is Georgia Gerard, and I'm going to let Georgia take it from here.
Thanks, Adam. I'm really happy to be here today. So today we'll be talking with Dr. Irene Harris, PhD. She is a staff psychologist with the Minneapolis VA healthcare system, and she has researched and published on moral injury, spiritual distress, and ways to enhance PTSD treatment by integrating a spiritual component. Today we'll be discussing her research on a promising approach to treating moral injury and spiritual distress called Building Spiritual Strength. So thank you again for joining us today, Irene. Do you mind telling us a little bit about yourself and what made you interested in this line of research?
Okay, well, thank you, and it's a pleasure to be here talking with you today. I got interested in this line of research back a long time ago when I was working as a practicum student in my master's degree in rehabilitation counseling. And I encountered one of my very first clients was a young man who had just about every oppressed identity he could possibly have and had some significant spiritual issues. He was African American. He was managing an addiction. He was managing schizophrenia. He had a history of being a convicted felon. He was gay. He was HIV positive, and I'm old enough that this was a time in life when that was a death sentence. And he also happened to be Muslim. He got involved with Nation of Islam while he was incarcerated, and that became a really important tool to him in managing his addiction. When he came to me, he was dealing with his HIV, and he was dealing with what it means to be a gay Muslim man who would be dying in the near future, and the scales were going to be evaluated in the very near future. And like a good little beginning prac student, I went to the library to try to get information on the spiritual issues and approaches I could use with this when I'm dealing with a gay Muslim client. And guess what I found in that library? There was absolutely nothing there to help me. And that is the moment when I vowed that in the future when practicum students or therapists go to the library to try to find advice on how to deal with clients' spiritual issues, that there was going to be something there. And from then on, I have been actively involved in research on spirituality as that relates to mental health.
Seems like having this first client was really personal to you, and then not having the resources to best work with him really inspired you to get into this research.
Yes, it was. I mean, not knowing how to ethically help when spiritual issues were central to the presentation was frustrating for me. Since I've come to the VA and have been doing a great deal of work with PTSD, it has become clear to me and many of the other clinicians around me that PTSD often brings with it a lot of spiritual issues. Many times they are central to what brings the individual to therapy. And so since coming to the VA, I've really focused my work on spirituality as that pertains to post-traumatic stress.
Well, that's really great. And before we get into your research, let's talk a little bit more about what that spiritual distress or moral injury is. Some of our listeners may not really be familiar with this concept or theory. How do you define moral injury and spiritual distress in the context of PTSD?
Georgia, that's an excellent question. We're really at the beginning of moral injury research, and there isn't necessarily a lot of agreement on definitions for moral injury. The most commonly used definition is Brett Litz's, and his definition is that moral injury are the psychological sequelae of events that challenge deeply held moral or values-related beliefs.
That is really helpful, and I know that people probably interpret that a lot of different ways, but it's nice to know what that most commonly used definition is. When you're referring to spiritual distress and moral injury, are they two different concepts, or is spiritual distress a symptom of a moral injury?
That's also an excellent question. My sense is that they are overlapping constructs. So, for example, somebody who has no spiritual background does not have a spiritual worldview, might experience moral injury as a completely non-spiritual event. They might be struggling with their own concept of themselves as a moral injury, or struggle with the idea of how morality and rules work in the world in general. However, in our military population, 90% of these folks are likely to believe in a higher power of some type, and our military is generally more religious and more conservatively religious than our general population. So most of the folks who are dealing with combat situations that might challenge moral, spiritual, or values-related beliefs are likely to think of them in spiritual terms. One of the reasons I prefer the term spiritual distress to moral injury has to do with the rehabilitation implications for the term we use. When we refer to moral injury, many people will hear that term and think that the individual experiencing moral injury has done something that is morally wrong. And 90% of the cases that I see, that's not actually the case. The individual may feel that they've done something wrong, and we will get into some of that later. But I don't want to start with a term that tells the veteran I'm working with that I think that they may have done something wrong. Similarly, the term injury many times can imply some sort of permanence. And moral injury or spiritual distress do not have to be permanent. We have had success in treating these things, at least in research. And I don't want veterans to think of themselves as being permanently damaged or injured.
That makes so much sense, and I like how you framed it as how your worldview is and how you would experience spiritual distress or not. And I like the reframe of moral injury versus spiritual distress. Spiritual distress seems much more approachable, especially for maybe clinicians working with veterans who might be struggling with this and how veterans perceive, what they're going through. So I really like the reframe of spiritual distress. I think that can help with treatment and make it look like you said, not so permanent. So that's really helpful for clinicians to know, and for those of us who work with veterans or service members, what should we be looking for? What signs or symptoms should be looking for, or being able to recognize that a veteran might be experiencing some spiritual distress?
There is more than one type of spiritual distress or moral injury. And so there are different clusters of behaviors that one might see that should be hints that you're looking at a moral injury or spiritual distress situation. What most of us think of right away when we hear moral injury is the internalizing moral injury presentation. And this is an individual who may be experiencing intractable shame and guilt, may think of themselves as unredeemable. It is not unusual in these folks to see high levels of social withdrawal, self-loathing, poor self-care, sometimes self-injurious behavior, and it is a risk factor for suicidal ideation and suicide attempts. There is another type of moral injury that we often see called externalizing moral injury, and this is an individual who, rather than losing confidence in him or herself as being a moral individual, they lose confidence in social authorities and social structures operating in any sort of moral or reasonable, responsible way. So this individual often comes in irritable, distrusting, doesn't like the VA, doesn't like governmental authorities. They can be very challenging clients to work with, and we will talk about some effective presentations with our externalizing moral injury clients as we go through this interview. It's really important to take the history well when you are looking at what you believe may be externalizing moral injury. If the irritability and distrust of authority precedes the exposure to a potentially morally injurious event, then that's not externalizing moral injury. That is likely some sort of access to pathology or some other phenomenon going on there. But if the individual was somebody who was essentially a rule follower and got along with authorities, didn't get suspended from school, got along with parents, got along with teachers, that didn't have a legal history before they were exposed to potentially morally injurious events, then that's an individual who is likely dealing with externalizing moral injury.
Okay, that's really helpful, and Irene, you've given such a great overview of what the common definition is of a moral injury and the differences between that and spiritual distress, and what clinicians should be looking for a veteran who may be either internalizing or externalizing, this moral injurious event. Now that we know more about that, and thank you so much for that great overview, let's talk about how you would actually go about treating it. So in one of your papers, which we will link to in this podcast, you write that using spiritually integrated interventions could help trauma survivors more effectively use their spiritual practices to help foster recovery. Can you tell us a little bit more about that and why incorporating spirituality into treatment is so important?
The primary reason it seems critical to work with spiritual concepts in this field is that most people, at least in our culture, will experience these kinds of issues as spiritual problems. The language they will use will be spiritual language, and it will be easier for them to respond to interventions if we are able to provide interventions using their language. For example, the research on meditation shows that meditation, when used for mental health purposes, is far more effective in India and Asia than it is in the U.S. because folks are working with the same kind of construct that their clients use on a day-to-day basis. So it is important that when we deal with spiritual or moral issues, we as clinicians are prepared to use the same kind of language and the same kind of concepts and cultural frames that our clients are using. That being said,
definitely seems like and it definitely seems like that would be more effective instead of expecting the veteran or service member or whoever we're working with to conform to our more therapeutic language we might use. So kind of meeting them where they're at and speaking their language would probably definitely build a better rapport and probably foster a better recovery, I would imagine. How would, in treatment, fostering this spirituality counteract any potential impacts of trauma, and how could that possibly protect against suicide risk? So how could it possibly be a protective factor?
And that's a very interesting and really well thought out question. So there is certainly ample research that shows that people who are more religiously involved and more religiously committed are less likely to be at risk for suicide. There's also an emerging set of studies in trauma survivors that show that those who lose their religious faith in the context of a trauma have far worse mental health outcomes than those who are able to survive a trauma with their faith intact. That being said, spirituality is a double-edged sword. While it can be a source of meaning-making and purpose in life, and a religious community can be an extremely important source of social support, all of which are protective, spiritual distress is also a significant risk factor for suicidal ideation and suicide attempts. Spirituality may be something that is helping a veteran who is managing moral injury, but spiritual distress may also be causing increased pain for a veteran who is managing moral injury. There are some pretty important ethical concerns to look at here. It is not within the scope of a mental health provider's practice to either encourage somebody to be religious or to discourage somebody from being religious. It is our job to sit with them on their journey, and when they come in with a particular religious identification, if it is important to them, we need to offer services that are consistent with the religious identification that they come in with. That being said, if there are high levels of spiritual distress, I have a lot of providers who have come to me and said, if my client's faith is causing him or her distress, why shouldn't I just advise them to abandon that faith? Well, the first problem with that is it would be unethical practice. The second problem with that is research on spiritual distress and spiritual support show that both can exist at the same time. So if somebody abandons their faith because they are experiencing spiritual distress, they are at the same time throwing out the protective aspects of their faith and their faith community. It is important to be aware of and make clients aware of the fact that their spirituality can be a resource, that it is not something that we would ever require of them, that they can go wherever they want with it, and at the same time give them opportunities and resources for resolving spiritual distress.
I like how you point out how spirituality is a protective factor, but when they are experiencing spiritual distress, that is when it becomes a risk factor. But like you've been saying, spiritual distress can be treated, given the right tools to clinicians and given the right space for the veteran to discuss it. So I like how you said it is a protective factor, but, when they are going through the spiritual distress, that's when it can become a risk factor for them. And knowing, like you discussed, that this population that we work with, a lot of them have experienced a moral injurious event, and 90% of them do identify that they are spiritual in some way. So it definitely seems important to research this. It doesn't seem like right now there's a whole lot of research out there on moral injury and spiritual distress. And it's really exciting to see the work that you and your colleagues are doing. So let's talk a little bit about that intervention you developed to treat post-traumatic stress disorder by integrating spirituality. I understand that this program is called Building Spiritual Strength, and can you briefly tell us about how this treatment was developed and what it looks like?
Oh, sure. Thank you for asking. So the program was developed based on several bench research studies looking at both the cross-sectional and longitudinal relationship between aspects of faith and belief and practices and resilience from trauma. What we did when we developed the intervention was we looked at ways to resolve aspects of spirituality that were associated with higher levels of PTSD symptoms and at the same time maintain sources of spiritual support that were associated with positive things like post-traumatic growth. The intervention is designed as a group intervention. It is designed so that it could be led either by chaplains or mental health providers, or the best way I like doing it best is to have both a mental health provider and a chaplain as co-leaders of the group. It is 8 sessions, and ideally we like to deliver the intervention outside of conventional mental health settings in places like faith communities and serve coffee and cookies so that it doesn't look like it's a mental health intervention. It looks like, well, it's a support group for vets at that church down the road so that it's less stigmatizing. The 8 sessions cover a variety of different topics. Session 1 is what you might see in any group therapy as sort of getting to know you and develop group norms. Sessions 2 and 3 are essentially couples counseling or communication counseling for the individual and their higher power. So we develop new communication tools that we use throughout the remainder of the intervention. Session 4 is on a concept that theologians know well. It's called theodicy, and it is how people struggle with the idea of if there is a higher power out there that is powerful and cares about us, why can traumatic things happen? Session 5 looks at prayer and meditative coping strategies, and sessions 6 and 7 are both on forgiveness. The final session is obviously focused on termination and moving on and helping clients find ongoing support for their spiritual development outside of therapeutic contexts.
It definitely seems like you did a great job designing this intervention to reach veterans who may hesitate to access that conventional mental health care services. Like you said, you try to do the groups outside of that context, have coffee, kind of making it feel more welcoming and more like a support group. So can you expand a little bit on why building spiritual strength might be a good fit for some veterans?
There are a number of ways that building spiritual strength might get to veterans who wouldn't otherwise receive services. In military cultures, chaplains are the only people who have complete confidentiality rights. If you go to a mental health provider, and in the context of the DoD, if that provider thinks that your ability to do your job is impaired, they have to break confidentiality and tell other people about it. In DoD, chaplains do not have to do that. So many veterans trust chaplains much more than they trust mental health providers. The idea of spiritually integrated services is less stigmatizing for many people than traditional mental health services. And while it is important to reduce the stigma associated with conventional mental health services, this is a step that we can use in the meantime to reach those veterans. There are also cultural groups that will benefit more from spiritually integrated care. For example, research shows that African American veterans and Hispanic veterans are more likely to view what Caucasian veterans think of as mental health problems, but for our ethnic minority veterans, they view these as spiritual problems. And for many of these veterans, it makes no sense when they go to the VA for help and somebody says, I'm going to give you medicine to help you with this. They're saying, I came to you with a spiritual problem and you are giving me pills. Why? That it does not make any sense in those worldviews to be pursuing what many of us think as traditional treatments for this. Building spiritual strength would be more consistent with those worldviews and be an opening for those veterans to get care.
I definitely think there's such a need for alternative treatments outside of, conventional mental health because, like you said, a lot of people don't trust mental health care, don't want to just be given prescription for something because it doesn't match with how they're experiencing their symptoms. So I think this treatment, is so great to have been developed, and I definitely think it could reach a lot of different veterans. So I want to go back to, so this is a treatment for PTSD. So do you feel that, or do you view moral injury and spiritual distress is different than PTSD? Or could you expand on the differences and similarities between the two?
Oh, sure. It's a really good question. In the research literature, we have not yet come up with an answer to the question of whether moral injury can exist in the absence of PTSD. So it's still ongoing. Moral injury is definitely something different from PTSD. So in PTSD, when it exists in its pure form, the symptoms have to do with fear that I'm going to be killed, fear that somebody else is going to be killed or hurt, etc. Whereas in moral injury, the symptoms have more to do with issues of existential worth and purpose. So we will see more in terms of guilt or concerns that social structures are breaking down, or shame, those sorts of things. The two often overlap. For example, somebody who has survived a motor vehicle accident may have PTSD in the absence of moral injury. However, somebody who has been in combat in war, who has both been at risk for being killed and been in a situation where he or she was forced to kill others, is more likely to have both syndromes at the same time.
So it's really interesting that the research on this is so new and we don't know much about it, and we don't know if you can have a moral injury outside of the context of PTSD. So there definitely seems to be a need for further research on this concept and theory, and as well as ways to best treat it so our veterans are getting the best evidence-based care that we can give them. You and your colleagues have developed a treatment called Building Spiritual Strength. So let's talk a little bit about the research that you and your colleagues have been doing. I read that you completed both a pilot and randomized clinical trial. Could you give us just a brief overview of your findings from those studies?
Sure. So briefly, the results of the pilot study, which compared people in a Building Spiritual Strength group to people on a waiting list to get into the group, found that we had clinically significant reductions in PTSD symptoms for those who were in the group. And when those who were in the waiting list group came into the Building Spiritual Strength group, they similarly had a statistically significant reduction in PTSD symptoms. At the time we ran that study, there were not measures of spiritual distress or moral injury that we actually could use to track those kinds of outcomes in the first study. We just finished a second randomized clinical trial, which was quite a bit larger than the first. And this time, instead of comparing Building Spiritual Strength to a waitlist control group, we compared Building Spiritual Strength to veterans who were receiving present-centered group therapy, which is also an established evidence-based treatment for PTSD. What we got in the second study is that we got the same level of remission of PTSD symptoms in both the Building Spiritual Strength and present-centered group therapy veterans. What was really interesting, though, was that for the veterans in present-centered group therapy, over the course of treatment from beginning to week 8 and then in an 8-week later follow-up, their levels of spiritual distress increased, while in the Building Spiritual Strength group, the levels of spiritual distress decreased. I think that this finding is particularly interesting, particularly since in the past few years there have been emerging a number of different research studies that show us that spiritual distress is an important risk factor for suicide. So if we have a treatment that reduces that spiritual distress when it may be going up in other treatments, we need to pay attention to that as a resource for veterans who present with high levels of spiritual distress.
And following up on that, it seems like your findings from both the pilot and the RCT you did were very promising. So will the manual for Building Spiritual Strength be made available for clinicians, or are you hoping that other researchers will take this on and test it in different populations, or what is your hope for that?
Actually, the Building Spiritual Strength manual is a government work product, so it is free to any qualified clinician who wishes to use it. All they have to do is email me, and I will send them the manual, and I will also connect them to a link that provides initial training in how to use the manual. I'm also available by VTEL within the VA, and generally speaking, I ask that people do a consultation with me in addition to using the web training so that we make sure that they're prepared to use the treatment manual effectively and correctly. But it's very easy to get the manual. Just get in touch with me.
Okay, wonderful. And it's so nice to hear that you've made yourself available to, answer questions or kind of provide consultation on that. Yeah, so anyone who is having a veteran or service member, someone they're working with who might be struggling with some spiritual distress, you can get in touch with Irene and maybe see if it would be an appropriate treatment to use with them. With that, we've talked a little bit about how, in this population, the majority of veterans and service members believe in a higher power, but it doesn't seem like discussing spirituality in traditional mental health treatment is a common practice. So as a clinician working with someone who's experiencing spiritual distress, what would you recommend they do to feel more comfortable talking about spirituality with that patient that is within their scope of practice, knowing that they're not a chaplain? So what would you recommend for them?
And this is really tricky because most clinicians get little or no training in dealing with spiritual issues. So it is really important when you're dealing with a client who's got central spiritual issues to do some things to help prepare yourself. One of them is very simply to do what I was trying to do as a first semester practicum student, go dig into the literature and read as much as you can about what is going on. Now there is a sizable literature on that, and in fact, Merrick Kopecks at the Vision II Center of Excellence for Suicide Prevention has published a lot of studies just in the past few years on the role of spiritual distress in veterans with PTSD. Another thing that you can do is consult both with your chaplain and with other providers who've got some facility with this. So consultation with other people, if you feel that that is enough. If you're extremely uncomfortable with spirituality, or you are dealing with a client whose spirituality is so different from yours that maybe you're afraid you've got prejudices against it or might not be able to provide services that are consistent with their spiritual beliefs, it's a really good idea to get in touch with your supervisor and perhaps get some ongoing supervision with the case.
That is really helpful, and it's just really, it seems like consultation with peers and supervisors and chaplains and just doing research so you can kind of really understand this veteran or service member's culture and their spiritual practices. And what would you say to, if you're working with someone and you just really you haven't had time yet to kind of look into what their practices are, and how do you feel about just asking the veteran or service member questions? Is that appropriate?
It is certainly appropriate to ask the veteran how they experience their own faith, and that is really important to understanding where they're coming from and how to work with these issues. That being said, in my clinical practice, I have frequently observed that veterans, for example, with depressive or anxiety-related cognitive distortions, often will distort some ideas that come from their faith. And so if you don't have a working knowledge of their faith culture, you might miss the impact of psychopathology on their perception about their faith. And that's why it is a good idea to work with chaplains. Most VA chaplains I know will know their way around comparative religion and different faith groups extremely well and can be very helpful in assessing whether or not a problematic faith belief is or is not consistent with the group with which that veteran identifies.
That's all really helpful, and I feel like we've learned so much about this topic and how to best work with it and best treat it. And so do you have any other advice for clinicians who are working with someone who's experienced a moral injury or might be experiencing some spiritual distress right now?
There are several tricky aspects of working with this that I have now seen a great deal in my practice that can be helpful for clinicians to be aware of and look out for. One of them is using guilt as a coping strategy, and I find that this is a very frequent presentation, that somebody has experienced something in combat for which they feel horribly guilty, and as you outline the situation and find out what's gone on, the clinician discovers that this individual has nothing to feel guilty about whatsoever. The event was not in any way their fault. This is a time when guilt is often used for the soldier who's in combat to create an illusion that he or she has control over a situation, because that is less scary than acknowledging that they don't have control over the situation. For example, if my best friend died, it had to be because I didn't do something right, because it's too scary to think somebody like my best friend, who was a good, effective soldier, can die while doing everything right. And that coping strategy can get people through the combat situation and get them to continue to use their combat skills to optimum benefit through that situation. But once they get out of the combat situation, that's no longer an effective coping strategy, and it is paralyzing. If somebody expresses guilt and they say that they have done everything they typically would do to resolve guilt, they may have talked with their clergy, they may have confessed, they may have made an attempt to take redemptive action for it, and the guilt persists, be suspicious that the guilt is being used as a coping strategy and it's being used to manage terror. And the trick to resolving that guilt isn't going to be talking about guilt, it's going to be talking about terror. Another thing to work on when somebody has intractable guilt is to acknowledge that when somebody is working in a combat situation, they are experiencing multiple moral contexts. For example, I hear many stories from veterans who were driving in Iraq or Afghanistan about having insurgents throw a child in front of the convoy. Obviously, the intent is to stop the convoy so that they can attack. But they're put in a situation where their instructions from their commanders are they must run over the child rather than stop the convoy. In their civilian moral context, that would never, ever be the right thing to do. In their military moral context, taking that action may save a number of other soldiers in their unit. If they don't get really clear that they are responding to more than one different moral context, it is very hard to resolve that guilt. We're looking at moral ambiguity in this case, and individuals who want to process this on a concrete level are going to get very frustrated and have more symptoms than people who can look at it and say, okay, there was more than one answer to what is right or wrong here. Another issue that I deal with frequently is veterans with externalizing moral injury. To deal with their anxiety about whether authority structures are going to treat them in a moral manner or not, they come in not trusting the therapist, because try as we might to not look like we have more social power than the veteran, we do in that context. It's really useful working with externalizing moral injury to use paradoxical intervention. For example, in a building spiritual strength group, if I'm going to assign some work to be done between sessions, if I'm working with a veteran who has a strong externalizing set of symptoms, I might turn to that veteran and say, now, I want everybody else to do this work, but I'm not sure you should. I am not quite sure you're ready to do that. It may be too much for you. So don't try it unless you feel really strongly that you can. That way, my telling that veteran to do the opposite of what I want him to do gives him the opportunity to act out, to be independent, to not be subservient to the social authorities that he or she does not trust, and still get the work done that they need to do. So those are the really tricky things that I think therapists need to be thinking about and prepared for.
That is very helpful, and for people who don't have a background in working with moral injury or spiritual distress, I think that was really helpful advice and things to be mindful of. And I definitely like that, kind of giving them options, or, I don't know if you're ready for this, like, I want you to feel comfortable. It gives them a little bit of power back and a little bit of that control they might be looking for. So I really like doing that. Let's see, so we've talked a lot today about, what moral injury is, what spiritual distress is, your treatment of building spiritual strength, and how that has improved PTSD symptoms in veterans in a group setting. And before we wrap up, how would you like to see this line of research progress, or do you have any plans for future research on moral injury and spiritual distress?
Yes, there are a lot of exciting directions that this could take. Right now, I have a grant application out to take a look at the role that building spiritual strength might play in addressing suicide risk. In our previous two studies, we have not really measured that. So I'd love to get a chance to do another trial and look specifically at suicide risks as outcomes. I would also love to do a trial of working with direct care chaplains to see if direct care chaplains can do this intervention independently. To date, we've had the intervention provided by psychologists and by chaplains who also have some specialized training in mental health, so chaplains who had a master's degree in psychology or were marriage and family therapists. I think that a really good chaplain may be able to do this intervention in some cases more effectively than a mental health provider can. There are differences in scope of practice that chaplains can do a few things that I am not allowed to do. So I would love to see some research expanding it there, and that would give our VA chaplains a lot more resources to bring to their collaboration with mental health providers.
That's really exciting that you have that grant application in, and I think there's so many ways that this research can be progressed, and I think the chaplains is such a wonderful resource, especially in the VA. I feel like they're maybe underused by mental health providers, so doing research to see if they can deliver this treatment, standalone, or if mental health providers are building spiritual strength with a chaplain, I think is such a wonderful resource, and I'm looking forward to see how your line of research progresses and what comes of it. It's definitely really exciting to see, since this is kind of a new topic and kind of in its infancy. So, Dr. Harris, we really appreciate your time today. I feel like I've learned so much from you, and you've given such a great overview of this topic that can be kind of complicated. So I really appreciate all the time you've given today. And do you have any closing remarks for our listeners?
I really appreciate your time and attention and your interest in this topic. And if others need some additional help or support with this, I'm assuming my email address will be published with the podcast. Do not hesitate to get in touch with me, and I'll be happy to talk with you more.
All right. Well, thank you so much. And that's it for the Rocky Mountain Myrick Short Takes podcast today. We appreciate you all for listening. And listeners, you can learn more about Dr. Harris and get her contact information by clicking on the links accompanying this podcast. You can also reach out to us if you have any comments or questions about what we discussed today. And please take a moment to subscribe to the podcast, give us a review, and share with colleagues. And please join us next time for more interviews on important work in suicide prevention.